Good morning, everyone. Thank you for being here in this amazing debate when we have two experts really to talk about this. As you know, a fetal growth restriction, I'm Dora Mayen from Mexico City. I'm on the board of the ISPD. As you know, fetal growth restriction is etiologically heterogeneous. Placental insufficiency and maternal disease are common, but chromosomal disorders, monogenic syndromes, skeletal dysplasias, imprinting disorders, and uniparental disomy can also present as growth restriction. The central debate is whether fetal exome sequencing, preferably trio, should be offered to all fetuses with FGR or selected to higher GIL subgroups. So let me introduce the debaters. The debate is the fetal exome sequencing should be offered to all fetuses with growth restriction. For is Anna David for University College of London, and against Lorraine Dugoff. It's an honor to be with both of you. So Anna David is a professor and consultant in obstetrics and maternal fetal medicine at University College London Hospital in the UK. She's also director of the Institute for Women's Health at UCL. Clinically, Anna specializes in fetal growth restriction and leads a team developing a novel therapy based on maternal VEGF gene therapy called the Everest program. Thank you, Anna, for being here. And Lorraine Dugoff is a professor of obstetrics and gynecology and the chief of the reproductive genetics division at the University of Pennsylvania School of Medicine. She's triple boarder in obstetrics and gynecology, maternal fetal medicine, and clinical genetics. Her research is primarily focused on the prediction of adverse obstetric outcomes, including preeclampsia and fetal growth restriction, and the application of emerging genetic technologies to clinical care. So thank you, both of you. We have the initial poll.
Dora, are we allowed to poll ourselves?
That's very nice, yes.
I think we should.
You can scan the QR sign.
So everybody needs to vote for.
Oh,
well, I disagree. I think everyone should vote against.
Oh, Lorraine, we're in for a bit of a battle here. It's a really tricky subject, though, isn't it? I mean, I think the world is changing so quickly that what I've enjoyed researching this debate is looking at where the data is going, and it's just phenomenal how quickly it's changing.
Yeah, I agree. I think it's also been really interesting and easy, unfortunately, to criticize the data. So I think we need a lot more. So
perhaps we can agree we need to do more research on this topic then.
Yes, it's changing.
Okay.
Yeah.
So I didn't have a QR code. I hope everyone who's participating had one come up, but it didn't come up on my screen.
It's come up on my screen on the.
Did it? Is it on it now?
You can click the link in the chat as well. There's a link that you can click as well. Because Lorraine, definitely you should be voting and vote for. Vote for.
Okay.
Oh, it's fairly evenly split. So it looks like I have my work cut out a little bit, but it's fairly equal. Okay. Is that the final poll, Pete?
Yes. I think it's the final one.
Okay, shall I kick off?
Okay. So first, Anna, if you want to talk
Thank you.
for.
So I'm going to share my slides. Hopefully everybody can see my slides. And I'm just going to put my laser pointer on if I need it. So fetal exome sequencing should be offered for all fetuses with growth restriction. I hope I'm going to convince you that it's absolutely a no-brainer that we should be offering this to all fetuses, all pregnancies affected by growth restriction. FGR affects around 8 to 10% of all pregnancies. It contributes to around half of all stillbirths, but especially if FGR occurs early, as you can see in this little baby down here. It has huge neonatal impact, causing cerebral palsy, breathing problems, infection, poor vision, bowel damage, as well as adult onset conditions for the neonate that's so affected, with high blood pressure, lower IQ, diabetes, heart attack, and stroke. So it's an important condition. It also has a maternal impact, so mothers who experience FGR, mainly if it's placental insufficiency or associated with preeclampsia, will have a higher rate of high blood pressure, diabetes, stroke, and heart attack. But in all people who are affected by fetal growth restriction, mums and dads, there's a high rate of mental health problems. So the big problem with fetal growth restriction is it's not a diagnosis. It's a disorder which has many complications, many etiologies, and you can have more than one at the same time. So mothers can have a pre-existing condition, let's say lupus. They can also have hyperemesis gravidarum, something I see frequently in my growth restriction clinic. There can be placental insufficiency on top of that, as well as structural, chromosomal, and genetic disorders. So I think we all have to be either more Sherlock or more Poirot, or if you're an Agatha Christie fan, more Miss Marple. We need to make a diagnosis. And I would say that we can only make a diagnosis if we actually include genetic testing. We split fetal growth restriction arbitrarily according to gestational age, according to less than 32 weeks or early onset, and after 32 weeks or later onset. Early FGR often detected at the 20-week anomaly scan, and late FGR often undetected before birth, and it's these pregnancies that often have unexplained stillbirth due to late fetal growth restriction. Some people think it's easy to diagnose early FGR. Yes, it's easy to identify a small fetus, very difficult to treat. We have no treatments, although I think taking a good medical history and identifying if there's a maternal disease is a really important thing to do. Late FGR, people think, yeah, difficult to diagnose, easy to treat. Well, I would say that treatment, in other words, delivering a cesarean section at 31 weeks or 36 weeks for a baby that's growth restricted is not really a treatment. It's bailing yourself out of a difficult intrauterine environment, potentially, but it often has a consequence for the fetus. So if we're thinking about FGR, we need to take a very holistic approach. We need to take a proper medical history. We need to assess the fetus and the placenta. Really important that we always have a look at the placenta. This is a narrow, thick placenta associated commonly with placental insufficiency, but also seen with genetic disorders that I've seen in my clinic. Important to have a look at the cord insertion as well, and look at the growth and do a really good detailed structural survey to correctly phenotype your fetus. Then have a look at all the Doppler assessments. Uterine arteries, umbilical arteries tell you about the degree of uteroplacental insufficiency, which can tell you about placental problems. And also have a look at the ductus venosus, middle cerebral artery, which tells you about the fetal response to how the placenta is functioning. And Doppler assessments are used to plan timing of birth and can be useful with making a diagnosis, but not necessarily. So I caution people, if you see abnormal uterine arteries, it does not mean to say the fetus is genetically normal. The fetus may have an underlying single gene disorder, which actually is not going to be picked up if you assume that it's all uteroplacental insufficiency. So then we move on to, is the fetus genetically normal? And many studies are now reporting amniocentesis, some of them chordocentesis as well. And then we go down the pathway perhaps of doing fetal karyotype, chromosome microarray, and then whole exome sequencing, which is better to be trio with mother, father, and fetus. And then I think we are looking into the future to whole genome sequencing. And of course, the way that this is done will very much depend on your environment, your facilities, your resources. In the NHS, we do a CMA only and a WES, WGS, with analysis of 1,500 genes. That's what's currently thought to be most cost effective. So aneuploidy, we know, is common in isolated FGR. When I call it isolated, I mean fetuses that don't have a structural abnormality. And those fetuses that don't obviously have a placental insufficiency. The rate was around about 2%. This is an old study published back in 2017. And the common things are trisomy 21, trisomy 13, trisomy 18, as well as trisomy 16, perhaps in confined placental mosaicism. What's the added value of chromosome microarray after a normal karyotype in isolated FGR? Well, this study published back in 2018 suggested a 4% incremental yield over a normal karyotype. It makes important diagnoses in FGR in addition to the karyotype, including copy number variants such as 22q11.2 duplication. Now, what have the August societies said about this? Well, joint position statement, which was published back in 2018 from ISPD, SMFM and the Perinatal Quality Foundation, said fetal sequencing is beneficial in a current pregnancy with a fetus with a single major anomaly or with multiple organ sister anomalies that are suggestive of possible genetic etiology, but no genetic diagnosis found on CMA. But they recognise that genomic technologies are developing rapidly, and their use for prenatal diagnostic evaluation is still incomplete and constantly changing. So I think this is out of date. I think we need to move on, and we need to decide that we're going to offer whole exome sequencing for fetuses that have growth restriction. This study back in 2023 from Powter was one of the first systematic reviews. 8 studies, 146 cases of isolated fetal growth restriction, 17 cases, 12% with an incremental performance for pathogenic or likely pathogenic variants. As you can see, 8 cases with a dominant inheritance pattern. Majority were diagnosed before 32 weeks of gestation. And if we have a look at the genes associated, yes, it's those to do with skeletal dysplasias, but also other things crop up. For example, Cornelia de Lange syndrome was very common in this study. But look at the explosion that we've had in the number of studies that are looking at exome sequencing after normal karyotype and microarray in isolated FGR. This was my search, which I did a couple of days ago. Look at the number of studies that are coming through. A summary of those studies, 9 studies showed an incremental yield of prenatal whole exome sequencing for likely pathogenic or pathogenic variants over karyotype and CMA in structurally normal fetuses. 875 cases from China, France and Israel, with the severity of FGR being either 2 studies where it's really severe, less than the 3rd centile estimated fetal weight, 7 studies less than the 10th centile estimated fetal weight, with an average incremental yield of 22.75% and a range of 7.1 to 43%. And even in this conference, 2 studies have been presented on isolated FGR. Nguyen from Vietnam, 22.1% single gene disorder, and Liu Sun from China, a 9.5% single gene disorder rate. There's obviously going to be a higher diagnostic yield if there's more severe FGR. So yes, higher if the estimated fetal weight is less than the 3rd centile compared to those cases that are between the 3rd and the 10th centile. But there's a huge variety of diagnoses with significant morbidity, skeletal dysplasias. Yes, the cool part, things like Cornelia de Lange have very severe, very mild severe phenotype, developmental delay, number abnormalities, surgery for the heart, and we need to make sure that parents get hold of this diagnosis because it is very often important to them. And what about placental insufficiency? If we have evidence of raised uterine pulsatility index, should we offer genetic testing? Well, the R21 assay in England suggests no. Just those that have all measures less than the 3rd centile with no evidence of placental insufficiency are eligible for WES. But I think we have to be careful. Not all FGR fetuses with single gene disorders have normal orders. This study is based on my group at UCL, where we're looking at early onset FGR with 66% of our cases of single gene disorders had evidence of abnormal orders. And this study from Georgia in France, published recently, showed a 50% chance of isolated FGR monogenic disorders had abnormal Dopplers. And we know that postnatal diagnosis is important and genetic testing is important in the gestational age. And even my colleague, Lorraine Dugoff, who's the debater opposite me, said that there's a complex array of single gene disorders that underlie SGA. And our findings support consideration of exome or genome sequencing, particularly in the setting of congenital anomalies or developmental delays. So why are we keeping it postnatal diagnosis when we know that parents want a prenatal diagnosis? Predicting outcome at FGR diagnosis, what is important to patients and clinicians? So prediction of death or fetal neonatal death is really important to parents and also clinicians. And parents want a diagnosis, they want to predict tests and a therapy. And if we're going to be doing therapeutics, we're going to need to rule out genetic causes of FGR before we offer therapy to make sure that we're not treating something which is untreatable by the therapy that we're going to offer. So huge FGR, £100,000 costs, mental health, and severe preeclampsia. And so I would say, if you agree that holistic care and making a diagnosis important in FGR, then you need to vote yes. Be more Miss Marple, Sherlock, and Poirot. Thank you.
Thank you, Anna, for your excellent presentation. Please remember to post your questions in the Q&A section. Thank you, everyone. Lorraine, please.
Okay, let me share my screen.
Yeah.
And let's see. Just need a minute. Okay. Can everyone see?
Yes.
Okay, excellent. Okay. So prenatal exome sequencing has really transformed prenatal diagnosis, as we all know. And the question, though, isn't whether it has value. It clearly does. The question is whether the current evidence supports offering exome sequencing to every fetus with fetal growth restriction. And I don't believe that it does. Before we look at the literature, I'd like to step back and ask what I think is the fundamental clinical question. Does every fetus with fetal growth restriction have the same probability of an underlying monogenic disorder? If the answer is yes, then offering exome sequencing to every fetus with fetal growth restriction would be a logical approach. But if the answer is no, and I believe the evidence clearly shows that it is, then our responsibility is different. Our challenge is to identify the fetuses most likely to benefit from prenatal exome sequencing. The answer to the question on the previous slide is no, because fetal growth restriction is not a diagnosis, as Anna said. It's a clinical phenotype, a common manifestation of many different underlying conditions. Some fetuses are growth restricted because of placental insufficiency, often associated with abnormal Doppler studies, preeclampsia, or maternal vascular disease. These pregnancies generally have a lower likelihood of an underlying monogenetic disorder. At the other end of the spectrum are fetuses whose growth restriction reflects an intrinsic fetal condition, such as a chromosomal abnormality or a monogenetic disorder or a skeletal dysplasia. Maternal disease, infection, and environmental exposures can also cause fetal growth restriction. So once we recognize that these are biologically distinct conditions, the debate changes. The question is no longer whether every fetus with fetal growth restriction should undergo exome sequencing, but the question becomes which fetal growth restriction phenotypes are most likely to harbor a monogenetic disorder. So the likelihood of a monogenic diagnosis depends on the phenotype. At first glance, these studies appear to report very different diagnostic yields, but I don't think they're actually conflicting. The studies enrolled very different populations of fetuses that had fetal growth restriction. And you can see some of these included predominantly isolated fetal growth restriction with evidence of placental insufficiency, whereas others enriched for earlier onset disease or more severe growth restriction or additional fetal structural abnormalities. And once you take the phenotype into account, the reported diagnostic yields become much more consistent. But before interpreting the diagnostic yields, I think it's really important to recognize several limitations of the current literature. And unfortunately, I think really there are many. First of all, there's substantial heterogeneity among the studies. They differ in terms of how fetal growth restriction is defined, the gestational age at presentation, the severity of the disease. Some studies include Doppler findings. Some studies don't report on Doppler findings. And also whether constitutionally small fetuses are distinguished from true fetal growth restriction. Also, one big problem, I think, with the current literature is that most studies are relatively small and they're retrospective cohorts. So I think one of the most important challenges is accurate prenatal phenotyping. So most studies classified cases as isolated fetal growth restriction based on prenatal ultrasound findings. Yet, in both the Ying and Liu studies, I'm just using these as examples, of several fetuses that were classified as isolated were ultimately diagnosed with skeletal dysplasias and other disorders that are typically associated with structural abnormalities that are pretty easily detectable on prenatal ultrasound. And I don't raise this as a criticism of those studies, but rather I think this illustrates how challenging prenatal phenotyping can be and how much the reported diagnostic yield really truly depends on the accuracy of phenotyping before sequencing. So for example, all of these yields that Anna presented, I think some of them are likely inflated just due to difficulties and challenges with prenatal phenotyping. I think many cases, unfortunately, in the literature that have been categorized as isolated IUGR truly are not isolated. And as you can see from these examples, I mean, we should be easily able to detect osteogenesis imperfecta, short rib thoracic dysplasia, for example, achondroplasia using prenatal ultrasound. So from a clinical perspective, this reinforces the importance of obtaining the most accurate prenatal phenotype possible. And whenever prenatal exome sequencing is being considered, I really think it's important that a detailed ultrasound evaluation, ideally performed by clinicians with expertise in fetal imaging, is an essential part of the assessment. And then finally, future prospective studies using standardized definitions of fetal growth restriction, together with detailed prenatal and postnatal phenotyping, will be important to better define the true incremental value of prenatal exome sequencing in truly isolated fetal growth restriction. I think one of the consistent findings across these studies is that not all fetal growth restriction carries the same likelihood of an underlying monogenic disorder. The phenotype really matters. So when the findings are most consistent with placental insufficiency, for example, the incremental yield of exome sequencing appears to be relatively low, particularly in earlier studies. As the phenotype becomes more suggestive of an intrinsic fetal disorder, the likelihood of a genetic diagnosis increases. So the question isn't simply, does the fetus have growth restriction? It's what's the underlying cause of the growth restriction? So when should prenatal exome sequencing be offered? Based on the available evidence, I don't think fetal growth restriction alone should determine whether prenatal exome sequencing is offered. I think we first need to carefully assess the phenotype, including the gestational age at presentation, the severity of the growth restriction, the ultrasound findings, again, getting truly, to be able to diagnose these isolated fetal growth restriction cases, Doppler studies, and the family history. All of that information helps us to estimate the likelihood of an underlying monogenic disorder and identify the pregnancies that are most likely to benefit from prenatal exome sequencing. When the phenotype suggests an increased likelihood of a monogenic disorder, I think prenatal exome sequencing should absolutely be offered and discussed with the patient as part of just shared decision-making. To me, that's really the take-home message from these studies. The phenotype should guide the decision, not simply the diagnosis of fetal growth restriction. I'd like to finish with a concept from John Hobbins. These illustrations on the left and the original concept are his. John was one of the pioneers of fetal ultrasound, and he was one of my mentors. He taught us many years ago that fetal size has to be interpreted in the context of the fetus's inherited growth potential. In other words, fetal size alone doesn't define pathologic growth restriction. And I think that same principle applies today. The diagnosis of fetal growth restriction alone shouldn't determine whether prenatal exome sequencing is offered. Instead, we need to understand why the fetus is growth restricted. What's changed isn't the principle, it's our ability to understand why a fetus is growth restricted. Thank you.
Thank you, Lorraine. Thank you very much. Please remember to post you in the Q&A your questions. We have 2 questions, Pate.
Yeah, we have a couple questions. I'll go ahead and read. First one is from Rosemary Rice. Thank you both presenters for thoughtful discussions. Dr. Dugoff, if not WES, would you favor targeted genetic testing, for example, for skeletal dysplasias that may have later onset and have cfDNA options?
Oh, so thank you for that question. So I absolutely think if you have a skeletal dysplasia, then we should be offering genetic sequencing. Absolutely. And, with skeletal dysplasias or suspected skeletal dysplasias, the yields with sequencing are among the highest. So I'm a big proponent of that. But this debate really, it's not about skeletal dysplasias. That's my point. It's about fetal growth restriction. So when you have fetal growth restriction, my point is that in those cases, sequencing should not generally be offered. And I think it's important to distinguish between skeletal dysplasias and isolated growth restriction. And I think that's the problem with the literature, is a number of studies have lumped skeletal dysplasias, and sometimes inadvertently, I think, due to shortcomings and limitations with their ultrasound, they've lumped these skeletal dysplasias in with isolated fetal growth restriction, and that's really inflating the yield that we're seeing with exome sequencing. So thank you for asking that question.
Great. And then I have another question from Samantha Stover. Do you think skeletal dysplasia should be excluded from the analysis for the detection rate of ESWGS for fetal growth restriction given the nature of underlying conditions? I don't believe anyone calls hydropic fetuses with an EFW greater than 99 percentile as macrosomic. Feel free to correct me if that's wrong. So I have always wondered, should the skeletal dysplasias always be lumped into the FGR category?
So I think it's really important that we do let patients know when there is fetal growth restriction. That is one of the counseling things that I say to them, is that it could well be a skeletal dysplasia. But it should be obvious to people that it's a short, long bones and there's a normal head size, a normal abdominal circumference. So I'm very comfortable with saying to parents, look, I don't think that this is a placental insufficiency FGR, and we can go down the route of doing non-invasive prenatal diagnosis, for example, offering an amniocentesis if that is negative, and going down the whole exome sequencing route. But I think that we shouldn't assume that it's not a skeletal dysplasia. Okay, we may not be able to pick all of them up. And I think if you are offering an amniocentesis to a woman, you need to make sure that you are offering the full testing that can be provided. And I think whole exome sequencing is the way to go. Because if you fail to pick up some kind of skeletal dysplasia, there could be a multitude of other things. And yes, we can't pick them all up now. But if we're going to make a proper diagnosis, we have to tell our parents that actually it could be an underlying genetic disorder. Even if it's only 2 or 3%, 4%, we still need to let them know we're doing an amnio. This is the full testing that is available.
Yes, and I just like to comment again that, and I appreciate the question about skeletal dysplasias, but that's really off the topic of this debate in the sense that skeletal dysplasias are a completely different category. They're very different from isolated fetal growth restriction, and I think it's really important to distinguish between the two, particularly when you're thinking about sequencing, because as I mentioned, the yield with exome sequencing is very high, and that's an excellent test for a suspected skeletal dysplasia. Whereas I beg to differ. I think, if you have a truly isolated fetal growth restriction, you really need to think about it and do additional work, including obtaining family history, really considering the whole picture and just not just getting exome sequencing on every single case with isolated fetal growth restriction. I don't think that's indicated. And I think, again, it really gets back to doing a detailed ultrasound. And because many of these skeletal dysplasias truly are, we can at least suspect them, even diagnose them. I think maybe we've gotten a little lazy now that we have sequencing, we can just order it and we don't have to do a detailed of an ultrasound. But truly, I mean, there's so many things we can see on ultrasound to really hone in on the fact that there's a skeletal dysplasia there.
Great. Carol Nolan would like to know what both debaters think about constitutional smallness versus FGR, whether these should be considered distinct phenotypes, and whether there is different value in exome sequencing for these respective concerns.
So I think that's really a very, very good question. I get that all the time. Working in London with a big international city, we have a multitude of ethnicities coming through. And obviously you're thinking about constitutional small baby. That is one of the differential diagnoses that is often at the top of my list. I've got a small mum and dad, and I'm saying to them, well, it's very likely this is an appropriately grown baby for you. And I would be saying to them, I can't rule out that there's an underlying chromosome disorder. I can't rule out there's an underlying genetic disorder. If you decide to go down the route of having an amniocentesis, then I think that one of the things that we should be doing, if we're going to be full and open and making a proper diagnosis, is to offer whole exome sequencing. Of course, if you do offer whole exome sequencing in that situation, you may potentially come up with a variant of unknown significance. We haven't really talked about that yet, and that really does open up a can of worms. But, we can't assume that a small baby with a small mum and dad is constitutionally small, particularly if parents move from other countries and they're in a country where perhaps they're eating a better diet and they're, it's really, really challenging. So I would say for full diagnosis, I would be offering, talking to them. I think we should be talking to them about genetic conditions, but I wouldn't necessarily be offering them an amniocentesis. And if they said to me, we really want one, I would say, okay, that's fine. But on a constitutionally small baby, I probably wouldn't be offering an amniocentesis. I'd talk to them, but I wouldn't push it.
And
Lorraine,
I agree. I agree with you, Anna. So I think it's really important, to make that distinction, which can sometimes be difficult. And that gets back to that slide I showed with John Hobbins, so he brought up the point that if you have a couple, where you have a football, or in the US, a football linebacker who's a huge person, maybe and their partner's a supermodel, and they're 6 feet 5 inches tall, their baby, fetus, if it's at the 20th percentile, that may be more concerning than you have what he refers to as a jockey and a gymnast, and they may have a fetus that's measuring at the 9th percentile. That's probably completely normal and constitutionally small. And so I think it's really important to take that into account. And I don't think that we should be offering sequencing. And like you said, Anna, even probably diagnostic testing in the setting of a completely structural normal fetus that we really suspect is constitutionally small. And that's where I think family history, and a number of these other factors are really important to consider.
But I think from a counselling perspective, we have, we now know that there's evidence showing that apparently completely normal fetuses, there's about over 1% risk of having some underlying genetic disorders. So our counselling has to be very much, we can't rule it out. And it depends on the degree of uncertainty and the risk that parents are wanting to take in terms of coming up with a diagnosis.
Right. But, I think really, truly, I think in order to really optimally address this question, this fundamental debate question, is we really need more data. I mean, I think the literature, the studies, it's great. We have some published studies, but I think they're really problematic. As I pointed out, a number of the flaws, the numbers are so small. And now we have the ability to do pretty, better and better prenatal phenotyping. And so I really think, moving forward, and you're doing this work, Anna, I think that we need more large studies with excellent prenatal phenotyping to really look at what are the diagnostic yields with exome, with truly isolated fetal growth restriction. And then we can really, decide. And I don't think we I don't believe right now we have that data to say that all of these cases should just be offered exome sequencing. And like you said, I mean, we need to consider, the getting a variant of uncertain significance and the cost. And I just don't think we're there yet.
Thank you both. Got a lot of questions coming in. Lena is wondering about VUS following WES, how to navigate that, and how that may affect families and their decision making.
So I've certainly been in the situation where I have had a family, they had a CVS, which showed a normal karyotype in CMA, and then at 22 weeks of pregnancy, there was evidence of growth restriction, isolated growth restriction, and we sent off the sample, and we had a potential abnormality, which was a variant of unknown significance. And we were teetering around the time of the potential sort of 24-week cutoff in terms of termination of pregnancy. And it became clear that actually the parents were happy to wait, and we got the mum tested. The mum actually had the variant. So I think we have to be honest. First of all, when we offer genetic testing, we have to say, look, there may be a variant coming through, and you need to be aware that this may not be diagnostic. It may be something that is in your family. So time is really important. Time is really precious. And that's why these kind of conditions, it takes a long time. You've got to do full counseling, be very honest with them. Continuity of care as well, I think, is really important. Lorraine?
Yeah, I think that, this really can be so difficult and so stressful for couples to get, a variant of uncertain significant result. And I mean, there are great qualitative studies showing that, even just in the realm of microarray, where and lots of couples have, even, regretted the fact that they chose to have genetic testing because they ended up getting a variant of uncertain significant result, and it caused so much stress, and it's really, really very regretful. But I think that the pre-test counseling is critical so that couples can expect this. And I think that when we do get this happens a lot, unfortunately, and when we get a variant of uncertain significance, I think like Anna said, it's more comforting, if we find that one of the parents carries that same variant of uncertain significance. But still, even then, you can't guarantee that, the fetal phenotype will be the same as a parent. I mean, you could have a fetus that's much more severely affected and an asymptomatic parent. And I think the most stressful cases, and we've had a number of them lately, are where you get a variant of uncertain significance that's de novo. And that puts patients, families in very, very difficult situations. I think that's something to be really cognizant of. And I think that's why I think we shouldn't be just shotgun offering all patients with, fetal growth restriction sequencing. I think we need to be much more selective in who we're offering sequencing to.
Thank you. Rosemary had a follow-up to her previous question. Not all SD have ultrasound findings, and some isolated FGR have short femur, for example. So that was the gist of their question.
Thank you, Rosemary. I hope you agree. So you agree with me that all fetuses with fetal growth restriction, they should be offered whole exome sequencing, particularly for that reason. Thank you.
I disagree. I think that's an overstatement and an overgeneralization. But Rosemary, I agree with your point. I think there are some skeletal dysplasias. I think generally the clinical milder phenotypes where, they're not going to have the, the significant ultrasound findings that we're seeing with OI type 2 or even achondroplasia. But so in those cases, there is some overlap, I think. Maybe some of those might get considered as fetal growth restriction. But I mean, you have to look at all the other parameters, because maybe, they should just be classified as having short long bones. Okay, and that's a different debate. Okay, because having short long bones, that doesn't fall within the definition of fetal growth restriction. So maybe really, Anna, what you're saying is that all cases with short long bones, if they're truly very, very short, maybe they should be offered offered prenatal exome sequencing to pick up those other milder cases of skeletal dysplasias. but to me, they don't fall within the same category as isolated fetal growth restriction. So I think that really doesn't address the debate question. And I still don't think that all fetuses with true fetal growth restriction should be offered exome sequencing.
Thank you. Question from Stephanie Duchovny. What do each of you do in your own practice for a workup for early onset presumed isolated FGR if a patient chooses invasive testing and if a patient doesn't choose invasive testing? I.e., what cfDNA single gene aneuploidy only?
Yeah. So I'm limited in the UK by the NHS R21 program, which basically means that if it's isolated FGR, in other words, it's all fetal measurements are less than the 3rd centile. But if there's any evidence of placental insufficiency, then I am not allowed to order a whole exome sequencing. And I have cases, I know that is incorrect. I have cases of single gene disorders that were picked up later when the baby was born. And I've looked back, this is prospectively collected data, and I've looked back at the Dopplers. We were doing full Dopplers, so MCA, ductus venosus, umbilical artery, uterine arteries every 2 weeks. And we could pick this up, and these children had single gene disorders. So you can't rule out that if you have a Doppler abnormality, that you're going to have that it's not going to be a single gene disorder. So I think we have to be very careful about what we do. So I have to let them know. I have to put it to a panel, and the panel at the moment says no, but I'm hoping that they will revise their discussion, because I think we need to have a look at what the evidence is out there. And I do agree with Lorraine, the phenotyping is really, really important. My full workup is obviously infectious disease checking, but I also do a serum placental growth factor, which is incredibly helpful at identifying if this is a placental insufficiency cause of FGR. I don't think it can rule it out, but it is very useful.
Thank you, Anna. Thank you, Pate, for your support. Thank you, Lorraine. So let's go to the last poll.
Oh, the poll's not coming up on, here, maybe here.
Yeah.
DJ, let's see.
So let's vote, please. Yes. Wow.
Wow, Lorraine, neck and neck,
Yeah.
eh?
Okay. Okay, the poll is closing. So, okay, 62% Lorraine is against to all the fetus should be offered for an exome sequencing. Of course, we have to consider also ethical, social, and economic aspects of different countries, but it was an amazing debate. Thank you for all of you to be in this debate, and thank you, Dr. Anna David, Dr. Lorraine Dugoff, and Pate for your support. Thank you very much. Continue seeing the next sessions.